Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm your host, Desiree Chappell. And once again this year, we have teamed up with the American Association of Nurse Anesthetists to bring you member experiences and highlight the amazing work of CRNA, or Certified Registered Nurse Anesthetists, and the work that they're providing around the country. Now, we've had some amazing conversations, very diverse. We've talked about opioids, peer assistance, pediatric anesthesia, enhanced recovery after surgery. We've talked to innovators in our specialty, taking care of transgender patients, vaping. That's just to name a few. And today we have the opportunity to catch up with a friend who's actually been featured on Top Med Talk and dive into another topical discussion, this time around residual neuromuscular blockade. Now, our next guest is the Director of Advanced Practice for the Department of Anesthesiology at Vanderbilt University Medical Center, involved with many other organizations. But he's here to discuss his presentation at the recent American Association of Nurse Anesthetists annual meeting, Brent Dunsworth. Hi, Brent. How are you?
Great, Desiree. Thanks for having me. How are you?
I'm good. It's so good to see you. Unfortunately, we miss it. We always see each other at the annual Congress at least, and it's been a weird year.
It sure has, but it's good to see you on Zoom and good to sort of chat with you again.
Yeah, absolutely. Well, it's so wonderful that we've been able to pair up with the AANA to continue to bring conversations like this to a global audience. You know, Top Med Talk has followers all over the world, listeners all over the world, and we've just surpassed 1 million downloads, Brent. I'm not usually one to do that, but shameless plug. We're making we're making a little dent.
Yeah, congratulations. That's a huge milestone.
You know, I really am excited to share everything that nurse anesthesia providers are involved with here in the U.S. because it's a huge part of the anesthesia community. And I love to highlight the things that we are doing to improve patient care. So I think to that point, the conversation that we wanted to talk about today really wrapped around what you were discussing at the annual Congress this year. The title of your presentation is Paralysis is Bad for Breathing, Outcome Criteria Associated with Residual Neuromuscular Blockade. Now, Brent, I feel like this topic has been around for a very long time. We're still kind of talking about it.
It has been around for a long time. I think we've probably talked about it in earnest for a good 15 years at this point. And we're still talking about it. And that really tells us that we've got an unsolved problem on our hands. And the more I learn about this, the more my eyes are opened to how much opportunity we have to improve in this area. And so as nurse anesthetists and certainly any anesthesia professional, we really pride ourselves on precision. And this is an area that we are not particularly precise. And we're learning so much about some of the both micro and macro outcomes that can occur because of residual neuromuscular blockade.
Brent, tell me a little bit more about your presentation and what you were talking about kind of specifically in that.
What I really wanted to bring across, Desiree, was, sort of the state of the art and what we know. And so a couple of things sparked my interest in this topic in the last year. And one of those was the publication in Anesthesiology that was titled How to Catch Unicorns and Other Fairy Tales. And so
that's awesome, by the way.
It is, and it grabs your attention because we don't typically see that type of a title in anesthesiology.
Right.
And so it grabs your attention and you look at it and you say, what is this about? And it's all about sort of the fantasies that are out there about the science of neuromuscular block. And so the quote, that they have is, this is really one of the recurrent, frequent failures in our practice. So I think it was intended to grab attention. I think it had some level of controversy to it as well. But that was what really sort of rooted the idea for this year's discussion at the AANA Congress.
Oh my gosh, that is so that's awesome. First of all, the title, but that we're bringing it up like this, and that we still, that there really still is a problem, because I think many providers don't really understand, that this is an issue post-operatively, and that there are complications that can be. I mean, I think all of us have learned that at some point, but Brent, one of the things I see is the root of this issue is that we don't really understand what our outcomes are. We don't know what the rate of post-op complications of anything really are, as most anesthesia providers. But talk to me a little bit about that.
Well, I think that's a good point. And certainly, if you look back in the past, right, once we have sort of dropped off, a comfortable, safe patient in the PACU, we may not have another touch point with them after that. And as a lot of our electronic medical records become digitized, that allows us the opportunity to see more data, right, beyond maybe the PACU drop off, and understand then how we can have impact. And so much like enhanced recovery, where we learned that decisions we make intraoperatively can have such an impact postoperatively, this is much like that. And so one of the big problems that we have is we know that the safest measure for extubation is a train to floor ratio, which of course is the fourth twitch divided by the first twitch of greater than 90%, right? Or 90% neuromuscular recovery. But many, if not most, departments in the country don't have a mechanism to measure that. Yeah. So that's a huge part of the problem. And the technology is sort of coming to market, and I would say maturing. And there's really two major types of products out there: those that are acceleromeographs, which really measure motion, or EMG type devices, right? And so the EMG type is sort of maybe coming out as something new, because one of the big limitations to acceleromeographs is they require motion. So if you're measuring, for example, on the thumb, and you're looking for a thumb movement, and the arm is tucked, you won't get valid data. So we know where we need to be, but we're struggling right now to have our tools keep up with that and really adopt sort of new practice of measurement. So we love precision, as I said earlier, and when we can see sort of a train to floor ratio on a monitor and realize what that means, and that we're out of the woods in terms of risk of residual neuromuscular blockade complications, then we're comfortable. But we don't have all of that. The tool belt is not quite full yet, but I'm hopeful that we'll see continued development and really application across a lot of different departments.
Yeah. So I have a plethora of questions. I think my first, because I mean, all this, I mean, I'm, as a CRNA and a provider myself, I think back into the OR. First, I guess my first question is, when did we get away from using twitch monitors? When did we, because I mean, we used just the simple, twitch monitors back whenever I was starting practice 15 years ago. I mean, that's, pretty average. And I mean, we were always using them. And it seems like, really in the last like 5 to 6 years that you can't find them around the departments. I talk to people all over the country, it's like they're not using them. What got us away from using this? Because that was kind of the standard of care, to make sure they had 4 twitches, that they could wake up, they could raise their head, all those different criteria. When did we get away from all that?
Well, it seems to have happened over the last few years. The most recent information that has come out shows that only about 40% of providers are using nerve stimulators of any type, which again was jaw-dropping to me. And I think part of that may hinge on the introduction of sugammadex, for example. And so we know that, clinically and pharmacologically, it is, very superior to neostigmine and an anticholinergic. And so I think that has perhaps made us feel more safe than we ever have before. However, it really doesn't exclude the fact that those patients, even if they get sugammadex, can also have residual neuromuscular blockade.
For sure. Well, talk to me. Do you know the prevalence? Because I mean, that to me is, we kind of got to know where we are on this. Is it truly a problem or is it not? I mean, obviously, if we're still publishing papers about it, it's still an issue. And okay, well, answer that question first because I got to know.
Yeah, so I'll answer with a couple facts that have come out of literature. So as you mentioned earlier, we wanted 404 twitches on our train of 4, and we wanted good tidal volumes and a sustained head lift and hand grasps, and that will give you somewhere between 40 and 70% train of 4 ratio, right? So it doesn't achieve 90%, and it's relatively subjective. The other thing that's interesting is they did a survey of experienced anesthesia professionals and asked them to assess how many twitches they felt on a train of 4. And of course, right, there was a computer knowing in the background what the correct answer was. 96% of experienced clinicians assess a higher train of 4 count than was actually present. So it's not easy, right? It's not like we're just not paying attention. It's just so subjective and so particularly difficult to sense, right? And so you can sense fade sort of when there is less than 40% train of 4 ratio, but beyond that, it's very, very difficult to sense with your own fingers, for example, or by vision.
Yeah. Oh my gosh. So tell me then, so we're still having this is still a problem. Patients are still waking up very, very weak. We're taking them, but they seem to us subjectively to be, doing well enough that we take them to PACU. What are people seeing? So like, why is this a problem? We're seeing this in PACU. They kind of fade there. And then, this translates into post-op complications. Tell me about that.
Well, a study was done not just a couple of years ago, and they looked at incidence of pneumonia, and postoperative pneumonia in patients that either did receive neuromuscular blocking agents or did not, right? And so we will assume that most were reversed, but the incidence of pneumonia in this population was 1.79 times higher for those that got neuromuscular blocking agents as opposed to those that didn't get any. And if reversal was not used on these patients, they were 2.26 times more likely to develop a postoperative pneumonia. And so that begs the question, I think, of, do we need to reverse based upon how much time has elapsed? So another study was done on that, of course, where just a small dose, right, a 0.3 milligram per kilogram dose of rocuronium, which, for a 70 kilogram patient is only 20 milligrams, still exhibited less than 90% recovery at nearly 3 hours, right? So the residual effects are huge, and we get away with it. I think we get away with it in young, healthy patients who, microaspiration, for example, is tolerated well, and maybe they have better cough and clearance mechanisms. But certainly in our vulnerable populations, which have really been identified as, patients who present with physical status classifications of 4 or higher, those that have lung disease or other muscular dystrophy type diseases, or are malnourished, which really constitutes a lot of our surgical patients, are significantly at risk for complications, pulmonary complications after surgery. And so, if you just look at the United States data, right, and you just look at inpatient surgery in the United States, there's a little over 50 million surgeries per year. So the economic impact of a pulmonary complication is about $25,000 per occurrence. So if 5% of 50 million, right, get a pulmonary complication, that adds up quickly to just over $60 billion in additional healthcare costs.
Wow.
Now, that's just inpatient surgery, right? So, I mean, you have to imagine if we account for outpatient surgery, it's going to be higher. So even if we can have a small impact on that number, even if we could impact 5% of the 5%, right? we're still going to save billions with a B,
Yeah.
right, of dollars in healthcare costs. And, not even to mention the pain and the suffering of someone who has to be ventilated post-operatively because they have a pneumonia, for example.
Yeah, absolutely. Well, we, do no harm. Like we should not, we know that there's a better way. So one thing that I find interesting in my practice have evolved over the years is that, rock uranium to me was very kind of unpredictable. So when you said, that you still could have a high rate of neuromuscular blockade after 3 hours, I mean, just with 20 milligrams, people would give 20 milligrams like nothing, And I think that there is a lot of variability with that. I think Sugammadex X has changed it because the superiority of using that. I find it really interesting. Are there still people that are not reversing rock? I mean, they're not reversing their neuromuscular blockade?
There are, and hence the pneumonia study looked at that. And so as we get into this, I think we have found so many different opportunities for us to be more precise in how we manage neuromuscular blocking agents. And so, yes, I think Sugammadex has been a game changer, and the outcomes are definitely favor Sugammadex, right? If it is used, right, the pneumonia rate goes down compared to when neostigmine is used, and respiratory failure goes down. All of those things are very true, but we also can't let our guard down and say, well, because we have Sugammadex, I don't have to worry about that anymore. I think we've all, as clinicians, probably had an opportunity to see a defasciculating dose, right, of a non-depolarizing agent prior to using succinylcholine for intubation, cause someone to get at least subjectively weak.
Yeah.
Where they sort of have this look of fear on their face and they say, I can't breathe. And of course, that the intercostal muscles have likely weakened or potentially become somewhat pharmacologically paralyzed, and they can't feel themselves breathing anymore. And so while that is brief, right, and likely in the midst of an induction, often patients remember that, but it speaks to the fact that each patient metabolizes differently and responds differently, and what might be a small dose for you is a large dose for me. And that's the world we live in right now. And I think those are our challenges.
Yeah. Brent, talk to me then about what should be the standard of care for patients that we are giving neuromuscular blockade to. Should it be that we monitor every patient, we get, tell me about that.
Yes, well, the suggestion, right, and actually the American Society of Anesthesiologists has a position statement about this, which also was controversial, but it is that, using nerve stimulators, right, is mandatory, right? So not using them is really not something that we consider a standard of care. That we do when we antagonize or reverse our neuromuscular blocking agents, that we preferentially have quantitative monitors so that we can see that we've achieved 90% or greater train of 4 ratio. And again, that becomes an issue of availability of technology and cost of technology and training folks to utilize new technology.
Yeah.
And so, we would all love to snap our fingers, I think, and have the latest and the greatest at our disposal. But that's not the reality of, sort of the capital purchasing world in the hospital right now.
Yeah. But I think that's a fair point. I think it's also really important to say, like, just because you can't get a quantitative measuring device doesn't mean that you shouldn't be doing some sort of, you shouldn't use a twitch monitor, to see.
Oh, I agree. And so I guess, then that begs the next question of, well, what if I don't have that?
Yeah.
What should I do? Or do I just throw my hands up and say, I can't do anything? Well, there are things, right? And so some of the mitigation strategies that are suggested is that you have a train of 4 count that's 2 or greater when you're utilizing, when you're not utilizing a volatile anesthetic, and actually a train of 4 count of 4 for reversal when you are using a volatile agent, because of course we remember that our volatile agents potentiate our neuromuscular blockade. So if you don't have it, then that is really suggested. And the reality is we can't always achieve that, right? I mean, some of the procedures we are providing anesthesia care for require a decent amount of neuromuscular blocking agent right up until the end of the case. So think crania and head pins, for example, where movement would be deleterious in that situation when they're in the pins, and then of course when they're out of the pins, it's time to do the neuro assessment. So we're challenging in many ways. And I will go back to one more mitigation strategy, or maybe two, actually. And the first one is you can use lower doses, right? And so see what a small dose gets you, especially on redosing, right? It seems like on redosing, sometimes people can be a little bit aggressive. If you have a reasonably long case, infusions are shown to give overall less muscle relaxant than by bolus dosing. And if you don't have train to floor ratio monitoring, then you always should reverse. Just because you don't know where you're at in terms of, the train to floor ratio. And so the only time it's really scientifically safe to not give a reversal agent is if you have train to floor ratio monitoring that is demonstrating 90% or better in terms of recovery.
Yeah, because you can't really, think about this. I hope that this wouldn't happen, but think about it like if you had to legally, defend what you were doing, you have no defense against.
You're right. And that's sort of a scary situation to be in. So I think we're learning, as we do. And that's one of the great things about anesthesiology is that you're always learning. And sometimes you learn things like this that are surprising, like, oh, I've been doing this for, a decade or more, and I can do that better. And so even if you don't have the, again, accelerobiography, right, or EMG type monitoring for train to floor ratio, you can still put a significant amount of attention, right, to how you're dosing neuromuscular blocking agent and how and when and in what amount you're reversing.
Yeah. Well, Brent, finally, one of the things I hear a lot from providers, especially newer providers, if I'm going to take over a case or, there during when they're waking up, like, oh, well, their tidal volume's fine. Maybe they're waking up and they're squeezing their hand or they're just making some kind of movement. Is that really enough?
Well, it's not. And, what we know is, again, that gets us only to maybe 70%, right? Those subjective measurements. And really what's interesting is the 5-second head lift, right? For example, right? 84% of patients who have a train to floor ratio less than 50% can perform a 5-second head lift, right? And that has been our gold standard, I think, for the longest time. And then interestingly, 14% of patients who have greater than 90% can't do it. So, it becomes very patient specific and, it's just not reliable. It's sometimes the best we've got. But it is certainly not, does not bear out as reliable.
Yeah. Gotcha. Well, Brent, I really appreciate you taking the time to talk to us about, are there any big points that we missed today talking about? Is there anything else that you really wanted to share to make sure that people choose to do the right thing?
Well, I think we've hit all the high points. I will just say that when you look at the probability of detecting fade in patients, with traditional train to floor, your probability of detecting fade is 1%. But with train to floor ratio monitoring, it's 99%. And so it's just such an improvement. Certainly something to keep an eye on this space and think about how this new technology could really be beneficial to your patients at your institution.
Yeah, absolutely. And everybody's asking, like, how do we get this into our unit, into our department? You can build a business case, it seems like, pretty easily for this now.
Really easily. And so, at the cost of the unit compared to, the potential savings that you will see from avoiding complications is a very easy business case to make. And there's enough data out there to now support that really in a strong way.
Brent, in closing, I didn't even ask you. I wanted you to tell me a little bit more about all the different things that you do and tell me about being a director at the advanced practice for the Department of Anesthesiology. Tell me more about that role just very quickly, because I think it's really cool that a CRNA is doing something like that.
Yeah, it's a really exciting job. And, within anesthesiology, we have, advanced practice providers on the entire perioperative spectrum. And so if we start at the beginning, we have a pre-op evaluation clinic. This is staffed by nurse practitioners and physician assistants. We have also recently enacted a high-rise clinic, as we call it, which is high-risk surgical encounter, where we can, really look at patients who have such significant comorbidity that their risk of having an untoward event in the perioperative period is high, and we develop a plan. And some of that plan might be that we correct anemia before surgery, right? Or add some protein to the patient's diet before surgery, or really just get them in a better physical state. So really cool stuff happening to improve outcomes. Because as you know, right, you sort of go to work in the morning and you see what room you're assigned to and you take care of what's in front of you. But if we can sort of improve the patient's status as they come into us, right, we can have such an impact on them. And then on the intraoperative side of things, we've got a very robust and growing CRNA component. So we're going to cross the 200 mark this year at Vanderbilt as we continue to grow, both within our campus location and outside of the Nashville area. So we've got great CRNA leaders and, just learning and growing and responding to today's needs in the most agile way possible. And then finally, on the postoperative end, we have a group of nurse practitioners and physician assistants who really manage our enhanced recovery process after surgery. So they'll sort of get people on path right in the holding area and then start seeing them again in the recovery room and to discharge and even beyond with some phone calls. And so what we have found is our ability to keep patients on path have really reduced their length of stay in the hospital. We've seen them mobilize and walk so much faster. And, tangibly now we have seen such a significant decrease in both intraoperative opioids, postoperative opioids, and the amount of opioids at discharge. And so as we face an opioid epidemic in our country, it's great for anesthesiology to be leading the way on that. And we're so proud.
Yeah, well, that is awesome. I mean, congratulations on all the work that you do, Brent. I know that you are so busy and in this space, so passionate about it. And it's so wonderful to talk to you and hear that passion and to know that, people out there are really, pushing the needle on this, because that's what we have to do.
I think we just keep moving forward and things will just always continue to get better. And thank you again for the opportunity to join you on Top Med Talk. Yeah. Always a joy.
It is, absolutely. Well, thank you so much for listening to Top Med Talk. You can always find us at topmedtalk.com, and we are on all of your favorite podcatchers. We're also on social media, on Twitter, Facebook, LinkedIn. You can find all the latest and greatest. If you're interested in a special topic, you can always look in our search engine, just type in, enhanced recovery, whatever it is that you want. We've probably talked about it if it's in anesthesia. And we will catch you next time. Thank you so much for listening. And thanks for the support of the American Association of Nurse Anesthetists. Brent, have a fabulous day. Thank you so much.
You as well. Thank you, Desiree.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.